Welcome to Meridia. This is your host, Dr. Umar Tariq. So today we will be talking about one of the most requested topics, which is actually how to get into radiology as an IMG. I received a lot of requests. I I kept on thinking, what's the best format to do this video session? And luckily, we had Fatima. She's a medical student who is interested in radiology. She was asking me these questions. So I thought it would be best if we, have an interactive session with her and I can answer her questions. And hopefully that will answer your questions that how to match into radiology as an IMG. So Fatma, assalamu alaikum.
Alaikum salam.
Thank you for joining us. How are you doing?
I'm doing great.
Okay. I will let you lead the interview. I will let you ask me questions, whatever you want to ask as a medical student in Pakistan who's interested in radiology. And I'll try to answer all the questions that you have to the best of my ability. We will try to keep most of this interview in English so that more and more people, specifically IMGs, can benefit from it. Go ahead.
Okay. Hello, everyone. So as we all know, radiology is one of the most competitive fields to applying for matching in United States. So I gathered some of the questions that I had and some of the questions that my peer had. And I also looked into the comment sections under the YouTube videos. So there are a few questions. I hope it is more helpful for you. So Dr. Tariq, for those who don't know, what pathway did you choose for radiology and what has been your journey in radiology so far in the United States?
So I graduated in 2009. So that meant I took my final year exams December 2008, January 2009. And then our diploma didn't come, or we didn't get graduate because we didn't get our degree till like June 2009. During this time period, I had this downtime. This was the time when I went to US for electives. So I did all my rotations in US in radiology. I went back home in August or September 2009. Then I relaxed for a little bit for a few months. I just used to play cricket and badminton and nothing else. So I was trying to relax in my life. Then I took my USMLE exams, took the step 1 exam. And then at the same time, I was looking for a volunteer research spot. So while I was studying for step 1, I was looking for long-term volunteer research. I was lucky I ended up getting paid research from day one. So, when I found that research spot, I took my step 1 and I started, I flew to San Francisco and started the research at Stanford University. While I was there, I studied for step 2 CK and CS and did research, took my exams, applied for residency. So I started my research at Stanford University March 2011 or Feb 2011. Yeah, March 2011. And I applied for match the year after. So 2012, September, I applied for match. I was working at Stanford University till June 30th of 2013. And July 1st, I became an intern. So I flew to Connecticut and I started my surgical internship. So yeah, a little over 2 years, 2.5 years of research. And then, I flew on June 30th, starting my internship on July 1st. 1 year of internship completed on July 2014. Then 4 years of radiology residency finished July 2018. I started my interventional radiology fellowship. It used to be 1 year fellowship then. Now it's a 2 year, and I was able to do another year during my residency training. So that helped. So 2018, I started my interventional radiology fellowship, completed in 2019. Now I've been an attending for 2 years, from 2019 to 2021.
So question number 1 is, what are the pathways to radiology?
Okay, thank you. That's a good question. So there are multiple ways to become a radiologist in US. If I have to break it down, I would say 5 pathways, and number 1 being the most common. Then in that order, 1, 2, 3, 4, 5. So the most common and the pathway that has helped so many IMGs to get into radiology, including me, is the pathway of research. So what you do is you spend 2 to 4 years of research, and at a very reputable university. I've made a video already how to get research as an IMG. So mainly you try to find a radiologist who is well published and who has researchers working under them. You send them an email, brief email. Hello, Dr. Tariq, my name is this and this. I'm a recent graduate, or I'm a fourth year final year medical student. I'm very interested in radiology. I came across these papers of you and really liked their stuff, and I would love to work with you as a volunteer research assistant or whatever. So you initially work as a volunteer research assistant for 3 to 6 months, and then you eventually get paid. Most of the people are eventually able to get paid. Now, it doesn't matter how many years you put in research. You can do 2 years, you can do 4 years, you can do 5 or 10 years. What truly matters is what you accomplish in that time period. If you are able to publish multiple abstracts, have multiple papers published, then you're considered very productive. But if you're not able to publish anything in 2-3 years, then you need to spend more time. So the quality of publication also matters. If you have something very groundbreaking and you publish it, even if it's one paper in a span of 3 years, that's considered significantly important, or much better as compared to publishing 10 case reports, right? So that's the pathway of research. That's what I did. I went to Stanford University. I did research there for 2.5 years, did a lot of other projects as well. And then that helped me because I got excellent letters from Stanford University, which helped me get radiology residency. So scores are important. They're universally, the better scores you have, the better interviews you're going to get, and your likelihood of matching is also going to significantly increase if you have better scores. But at the same time, scores alone are not enough. So if you have very high scores, 260s, 270s, and you think you're going to match into a competitive specialty like dermatology, radiology, neurosurgery, that's not happening. You need to supplement your CV with something additional. So that is the first pathway. That's the pathway of research. This is, by the way, my own personal categorization. I've helped so many IMGs get into radiology in the past 10, 15 years, and this is what I've seen, how they all succeeded. So the second pathway is doing a complete residency or training in something related to radiology. So I know people who have worked, who did nuclear medicine. A lot of people I know, they did full nuclear medicine residencies, 4 years, just to get into radiology. Because radiology is so competitive, they were not able to get research spot, but they were able to get nuclear medicine residencies or some other residency that is somewhat related to radiology. The problem with nuclear medicine is that most of these people are not able to get a job after doing the nuclear medicine residency. The only option left for them is actually do a radiology residency. So that's the next option. I personally know 4 IMGs who did nuclear medicine residencies from very good places, and then they kept on applying during their nuclear medicine residency. One of them was able to match after a couple of years of nuclear medicine residency. The other 3 had to complete their nuclear medicine residencies, and then they matched into radiology. The third pathway, which is actually becoming more and more common now, is doing a residency in a clinical specialty, and it doesn't have to be related to medicine. So one of the big ones that's coming these days is internal medicine, family medicine, pediatrics, neurology, peds. One of my very good friends, he's a neurologist. He was an attending neurologist, and then he started his radiology residency. He was my classmate, very good friend. He did that. I know at least 3 different people who did full internal medicine residency. They did chief resident a year. They were hospitalists, and then they were able to get into radiology. They tried, but most of them were not able to get into radiology straight because they didn't have any research experience. Their scores were good, but they didn't have any research experience. So first they got internal medicine residency, became hospitalists, and finally, after working as a hospitalist for 1 to 2 years, they were able to get into radiology. The fourth pathway is not doing any residency in US. What you do is you do residency in your home country, Pakistan, India, UK. And I know a lot of people from India, from UK, and very few from Pakistan. They do full residency training in their home country. Let's say if we talk about Pakistan, they take FCPS Part 1, Part 2. And also they pass USMLE scores, exams, right? They get good USMLE scores. Then they get the fellowship. Sometimes you're lucky and you're able to get these fellowships straight out of residency or without any research. I know a lot of people, when I was at Stanford, there were a lot of research fellows who did their residencies in their home country, let's say India, UK, and then they were doing research fellowship at Stanford University at that time, or Johns Hopkins, or Harvard, at these top places to get a clinical fellowship. Once they spend a year or 2 doing research fellowship, they are able to get clinical fellowship in radiology. And then it depends, typically you need to do 3 to 5 years, typically 4 years of fellowships, and then you can work as an attending. That's the pathway, alternate pathway of ABR, that you can get, work as an attending without doing the residency. So that's that. The fifth pathway is rare, but it's getting actually more and more. Relatively, I'm hearing more and more people getting success to it. And that is, if you're married to a spouse or somebody who's a radiologist, or at least very well known in the program, even could be a fellow or resident, but typically an attending. So in the past 3 years, I've spoken to 3 IMGs who have matched successfully. They did some research, but it wasn't any groundbreaking research over the years. But the biggest pull was that their husband or wife was very accomplished, very celebrated attending radiologist or a fellow who they wanted to become an attending in the program. So they didn't want that person to leave, because what's going to happen is if the program doesn't take your spouse, you as an attending are going to relocate with your family. So they were able to match as an IMG into radiology, and their husband did the first, second, or third one of those pathways. So a little bit of help from the spouse also helps big time. That if your spouse is a accomplished radiology attending, then they can help you. It works, I will say, 60 to 80% of the time, and it also depends what level. Let's say if somebody's an academic chief or a section chair, that person is going to have a lot more pull than as compared to somebody who's a new attending. Okay, so these are my own 5 pathways to get into radiology as an IMG. There is nothing hard set on stone, written on stone about it. But I think these are the 5 pathways that have helped a lot of students who I have mentored in the past 2 years. Number one pathway that I recommend everyone is to do the pathway 1. Do 2 to 5 years of research. One of my very good friends, he didn't score highly in research. His scores were actually very, very poor, and he was doing research at Stanford University with me. He ended up doing PhD in research, in stem cell research. He didn't match for radiology residency for a span of 4 or 5 years. After doing his PhD, he matched at UPenn, which is one of the number 2 or number 1 program in the country. And he was an IMG. He was able to match at a top place. All these top places, including Yale University, including Harvard, including UPenn, WashU, they have all taken IMGs, but those IMGs are not your regular IMGs with very high scores. That's not the differentiating factor. The differentiating factor is those are the IMGs that have scored exceptional, not only scored high, some of them didn't have those high scores, but they were the ones who did a lot of significant research, published a lot of papers, had a lot of posters and abstracts.
So next question is about the pathway 1. How do you cope up with the fact when you are the one who's stuck in research and you feel like the other peers are progressing on with their residency?
It's a very good question and a very tough question to answer. The reason being that, in general, in life, you don't know where you're going to end up, right? We are all working hard in our life, thinking that we will reach our destination. So that is the time you need to have faith in yourself. That's why I always say never give up, never lose hope, because it is about never giving up. It is about having faith in yourself and having a hope that you will eventually succeed. Because once you eventually succeed, it's all worth it in terms of whatever you're thinking, right? In terms of professional success, in terms of monetary success. You're not running for somebody else's dream. You're not trying to fulfill somebody else's objectives. You're trying to achieve what you set out for. So that you do need a lot of belief in yourself, because those are the tough moments and they will test you. In my family, my brother started his residency, who's younger than me. My cousin started their residency, and I'm still doing research or still doing residency. It is tough, and anytime you pick in a path or a residency or a training that is longer than medicine is 3 years, radiology is 5 years diagnostic, and interventional is 6 to 7 years, depending on how you do it. So that's a long path. You just need to have faith in yourself that eventually it will all be worth it, and I can assure you it is. I wish there was an easy way to say that, but it's not. And in the long run, it eventually evens out, or you actually do better if you're looking financially. What helped me was I knew a lot of people who took their USMLE exams while they were a medical student, got into internal medicine residency, became a hospitalist. So when I asked them if you guys had any regret, and their regret was that they wanted to aim for something more competitive, but they didn't do it. So once you become an attending, I think it truly matters. See, there are all these people who are going into internal medicine residency and then doing radiology. So there are people like that as well. I'd give you the example of my very good friend, my classmate who did the neurology residency, who became an attending. And then he said, okay, no, I want to do radiology. He did a radiology residency, and now he's doing interventional neuroradiology fellowship. So for him, I think he's spending 12 years in training. So if radiology or surgery or neurosurgery or dermatology is your passion, then nothing can stop and nobody can stop you from pursuing your passion. Yes, no passion can be achieved, no dream can be achieved without some difficulties, without some hardships. So I guess you have to hang in there.
So materialistic incentive wise, what are the pros of choosing the pathway one, that is first research and then your residency?
So that's a very good question. Thanks for asking that. Before I answer this, let me say what one thing that really helped me was that when I was a fourth year student, I decided that I wanted to get into radiology. I tried to reach out to as many people as I could who have matched into radiology in US in past 20 years. So let's say if anybody has come from Pakistan and matched into radiology in past 20 years, I had spoken to them at some point. So that really helped. And that helped, listening to all these stories, you don't need to reinvent the wheel. This is something that worked for this one person, this is something that worked for this person, but then you talk to 10 other people and this is what worked for them. So you realize that, okay, these are the zebras, these are the outliers. They just got matched because there are only one or two people who matched this way, but there are 10 others who have matched this way. So that really helped me. So to answer your question, that was the pathway one. Most of the people who matched into very competitive residency, including radiology, including neurosurgery, including dermatology or ophthalmology, they were the ones who'd spent a lot of time doing significant research. Now, what's the benefit of that? In case you guys are too young, you're medical students, so you don't understand this, but research helps you significantly. And you realize this, unfortunately, after completing residency. And I'm talking about internal medicine people. Let's say if you want to get into gastroenterology, cardiology, interventional cardiology, some of the critical care even now is getting more and more competitive. If you want to get into a competitive field, the only thing that sets you apart from your peers is significant research. The problem is a lot of IMGs don't realize the significance of a research. So then they graduate from residency, they're not able to get fellowship. That is the time that they start doing research. I think it is easier to do research when you haven't done a residency, you don't have a family or your kids are younger, you're by yourself, you can put in that many longer hours and do significant research, as compared to once you have become an attending or have completed your residency, you're used to making a certain amount of money, you're used to do now you become an attending, you're getting the big salary jump, your kids are older, you have a family to look after, there are more responsibilities. So that time when you have to do research, I don't think you can set apart 10 hours of research and work at the same time as compared to before the residency. So that is one thing that in general, whenever you do research helps you significantly get into a very good residency, B, get a very good fellowship, C, even get a very good job. And then once you're an attending, and I'm saying this after being an attending for 2 years now, once you're an attending, it sets you apart from your other attendings as well, because you are not just talking stuff based on your experience. You're talking data, you understand the statistics, you can read papers and understand what is right, what is wrong. And when you're talking, you don't only know the literature, you understand the literature, you understand the statistics, you understand research methodology. So that is, if anything, if I have to go back in time, I will do the same thing. I wouldn't do another residency. I will do the research. Probably I will try to be more active in research because I didn't understand the value of research while I was doing it. I think I would have tried to accomplish a lot more. But that's what it is, right? You are a better resident, a better fellow, and a better attending, and a better clinician if you are a better researcher.
So my next question is, what type of a doctor radiology is looking for?
Thanks for asking that. The thing is that there is a myth that somehow radiology is looking for people who don't want to see patients who are introverts. That's not true. Yeah, if you're an extrovert, I was an extrovert, so it was a little awkward for me because you come and sit on a chair at 7 a.m. and then you get up from the same chair at 5 o'clock. But it's not that. Honestly, a lot of people think there is actually everyone's read a blog about what are the right reasons to get into radiology, what are the wrong reasons to get into radiology. And let's say that I initially had all the wrong reasons in mind. You're good with computers, you should go into radiology. You don't like patient contact, you should go into radiology. These are all the wrong reasons. The good reasons are, okay, you have a detailed oriented personality. You focus on the details very well. You're a multitasker. Stuff like that. You love reading books. So that is one thing I really, really underestimated. You really need to study a lot, and like you need to read a lot in these specialties, non-clinical specialties like radiology and pathology. With internal medicine, surgery, neurology, peds, these clinical specialties, you learn a lot on the go. Okay. But unfortunately, in radiology, the clinical side is very different than the exam side. The clinical side, you learn the clinical side on the job, how to become a radiologist. But the exams, it's very tough to mirror the experience of a view box when you're reading a CAT scan or an MRI. It's not technically possible. So the exam is very different, right? They will show you an image and expect you to come up with the diagnosis based on an MCQ. And a lot of times, what I personally feel that the exam in radiology is very much like the exam in Pakistan. It's not very clinical. It's not very conceptual. Either they're testing your memorization or stuff like that. And physics is a very important part of radiology residency in the US. So you need to be good with memorization. You need to be prepared that you will be reading a lot and memorizing a lot of stuff if you will be going into radiology. So if you're good with books, then I think radiology is helpful. Also, one more thing is that there's a little bit of teamwork in radiology, but most of the times it's not that significant of a teamwork as compared to like in a clinical specialty like surgery or internal medicine. Because the structure of a service in internal medicine, like, there's an intern, there's a resident, there's a senior resident, there's an attendant. So you are like a team. And then there's a chief resident. So you work it together as a team. You're not working directly with an attending. If you do something wrong, your senior resident will teach you. In radiology, that typically happens only in the first year, that your senior residents will teach you and stuff. Mainly 99% or 95% of the radiology education and residency, you're working one-on-one with the attending. So you're working directly with the attending. There is no senior resident, chief resident in between. They're working with their own attendings. So we're not really looking for people who want to work more like a team or are focused towards teamwork or a team player. We're looking for people who are motivated. Like you have to read your own 20 CAT scans. So nobody's going to help you read those 20 CAT scans. That's your job. That's I think one very important thing, that you need to be motivated enough to read enough studies to learn by yourself, because there is and you can read 5 studies or 10 studies, and there are certain programs you can get away with it without reading much, and there are certain programs that will punish you for that, penalize you for that. But that's it. Most of the education is more individual based in radiology. I hope that answers your question.
So again, next question is, how much patient interaction do you get in radiology, and is patient interaction a good factor for deciding a specialty of your choice?
See, I used to value patient interaction a lot, and then I read something that patient interaction is one of the most overvalued things when you're trying to decide a specialty. When I was a medical student, I read it, and I was like, interesting. They say by the time you've worked in your specialty for 10 to 20 years, that charm of patient interaction dies away, and it becomes more like people think it's more cumbersome. So based on that reading and talking to more senior doctors, I realized that it's probably not that important, and I thought I'll be okay. So I got into radiology. But I was surprised, even in radiology, there is significant patient interaction. You're doing procedures in interventional radiology. You're doing fluoroscopy, so peds has some procedures. So there are certain sections of radiology in which you work directly with patients. That's good, but it wasn't enough for me. And when I graduated from residency, I realized, no. Patient interaction is important for me. And I really needed that. I'm an extrovert guy. I like to talk to people. I can't be sitting in a room by myself. So that's why one of the factors why I ended up doing interventional radiology. The problem with clinical specialties is that there's a lot of clerical work. There's a lot of discharge planning. You're calling these, talking to the discharge planners. They're looking at short-term rehabs and all this stuff. So there's a lot of this work that is not technically clinical, it's more clerical. So that is one of the biggest things that the people who work on clinical side, they hate. Also, a lot of times at odd hours, a family member will come and will like to speak to you. They weren't involved in the care or anything before, but now they're questioning every single judgment that you made. So these are some of the frustrating aspects of the people I know who work on clinical side. So I think patient interaction is overvalued, but at the same time, I don't think that you should get into radiology just because you're thinking that you won't have any patient interaction. In IR and fluoro, you will have some patient interaction. But then once you become a diagnostic radiologist, depending on your job setting, you can get into a job where you don't have to deal much with patients.
Okay, so my next question is that what are different branches of radiology and how do they differ on lifestyle?
So let me quickly give you the number of different specialties or fellowships available for after radiology. So emergency radiology, interventional radiology, pediatric radiology, neuroradiology, musculoskeletal radiology, chest, cardiac imaging, and there are certain other ones as well. So that's mainly the bulk of it. And general radiology, in which you do a little bit everything. Ultrasound is there, mammography, breast imaging is there. So, to answer this, I don't think there is anything like, you do this fellowship, your lifestyle is going to be like. The job is very different. Most of the times, what I can say is interventional radiology has a little more different lifestyle because depending on where you're going, the call schedule is going to vary between Q3 to Q6. You're going to be on call every third day versus every sixth day, and your call could be extremely busy versus you might go on your call only once a month. That depends on the type of job you are doing. Emergency radiology, typically they have 7 nights on or 7 days on, 14 days off. So that's a very laid back lifestyle that you're only working 1 week and then you're off for 2 weeks. That's emergency radiology. Most of the other practices, what they do is you're working, Monday to Friday, 8 to 5, and then you take once a month, a weekend call, Saturday, Sunday, 8 to 5. That's for diagnostics. Interventionalist, it varies, typically you are on call once a month. And when you're on call, you're holding the pager or the cell phone. So it's not like I will say, okay, well, if you get into interventional radiology, your lifestyle can be tougher because you're on call more. But at the same time, if you go to a place that's relatively less busy, is a level 2 trauma center as compared to level 1 trauma center, you're holding the pager more frequently, but you don't have to go to the hospital that frequently. So there is nothing like being on call for diagnostic radiology anymore. Now it's when you're on call, you're actually in the hospital, you're on a shift, you're reading studies from 8 a.m. to 5 p.m. Even if it's weekends or even if you're doing evenings or nights, you are reading studies. The rise of emergency radiology has helped a little bit because a lot of places have emergency radiologists covering at night. They do everything like a general radiologist at night. So that's emergency radiologist. Some people have emergency radiologists covering the evenings as well, whereas other places will have a general radiologist or like a diagnostic radiologist take call in the evening. So that, these things are very variable. It depends on what kind of practice you're in. Is it private practice? Is it academic? How frequent is your call? And you learn more about these things once you start your residency. I don't think the fellowship impacts your lifestyle that much as compared to, let's say, medicine. That being said, I think I will tell you one thing, even if you do interventional radiology or diagnostic radiology or any of the subspecialties, I think the number of hours that you actively work are way less as compared to, the clinical specialties. But at the same time, I also feel the amount of work that you do in those hours is way more. Because think about it, like if you're a surgeon, you do a surgery, Then you get your downtime, you're sitting, waiting for the patient to go, waiting for the next patient to come. You have a downtime of half an hour. In radiology, once you're done with one CAT scan, there's this next CAT scan, you start reading it for, your next study immediately. So you're reading studies back to back. There isn't much downtime. As a trainee, you get time for conference and stuff, but as an attending, the only downtime you get is when you get up from your chair to get tea or coffee, or when you take a restroom break. So the amount of work that you do within an hour is a lot more intense as compared to working in a surgical or non-surgical clinical specialty.
So my next question is that what are the pros of being in radiology in the United States?
Okay, so to answer this question, let me ask you this. When you say pros, what do you mean? Pros of being a radiologist in the US or pros of being a radiologist?
I think both.
So, see, I don't want to brag about it that I'm in US, and that's why I'm going to say, oh, US has the best training. But, US does pretty much have the best training, specifically in radiology, the PAC stations, the CAT scanners, the MRIs, all the stuff that they have, especially, as compared to Pakistan or, India, like, they have a lot more equipment, so you get to learn on the latest MRI machines. You get to learn about the how they read the studies, how they're reading them so fastly, how they can look at multiple sequences on the MRI. I think the quality of education is significantly better if you do training in US. And also, I feel that in general, most of the specialties, they have much better training in US as compared to any other country in the world. So I think one more thing is, like, if you're a radiologist in US, you can pretty much go in any country in the world and you can practice. And I have spoken to people who are interested in going to New Zealand and they get the job there. UAE, Saudi, Pakistan, India, so you can go pretty much anywhere in the world and practice or open your own practice. The problem is, like, I know a lot of people who come from UK and Australia to US. I don't know that many people who go from US to Australia or UK. And the reason that is, like, the quality of education is the best in US. So sorry, I don't mean to brag, but that's the truth, that you will get much better education if you come to US for training. Now, the next question that you have is, like, pros of being a radiologist. See, I think the biggest pro is radiology is considered, though it's changing slightly, but it is actually a lifestyle specialty. It has much better lifestyle as compared to the other specialties. The biggest benefit of being a diagnostic radiologist is that you are not on call that much. You're doing shift work. And when you're home, you're home. You don't have a pager. When you are on work, you're on work. You're actively reading studies, 8 to 5 or 8 to 6, whatever you're doing. After 6 o'clock or 5 o'clock, is nobody is going to bother you. Your time, your free time is your free time. Also, vacation in general, when I talk to my friends at clinical side, they get like 4 weeks of vacation. Radiology has 8 to 13, 14 weeks of vacation. That's pretty standard. So they have much better vacation. The lifestyle is much better after being an attending. A lot of people, like I said, told you, practice teleradiology. They work from home, so they have a much nicer lifestyle. You just go to your basement or one of your rooms and you switch on your station. You do reporting for 8 to 10 hours, and then you go back to your bedroom, right? So that's a big pro of being in radiology. Yeah, I think that's mainly it. Lifestyle, I told you about emergency radiology. A lot of people I know, they do 1 week on, 2 weeks off. So hospitalist just has considered to have a good lifestyle, 1 week on, 1 week off. Emergency radiology is way beyond that. It's 1 week off, 1 week on, 2 weeks off. So I think overall, in terms of lifestyle, I don't think there's better specialty. That being said, let me warn you, if you go to an academic place, or a very busy private practice, you're going to work a lot more. But these are the compromises you make. If you're in an academic place, they will expect you to read, like, I don't know, 50 CAT scans or 10, 20 MRIs and 20, 30 ultrasounds. And it depends on your personality. If you can multitask and if you can work at a fast pace, I think you will do phenomenally well in radiology.
Now coming to the cons of being a radiologist.
You need to read a lot. You need to read a lot of books. And I'm not studying for step one, you would think that, oh, it's a lot. No, think about it. And I say this to a lot of my friends that head to toe, you need to know the anatomy of everything, right? Head to toe, you need to know what's what that part of the brain as compared to what ligament would you see in an ankle or a wrist, then lack of patient interaction. Yes, and it depends on the personality type, right? There are certain people who like that you don't have any patient interaction. Then there are certain other ones who really miss the patient interaction. So unless you're in interventional radiology, there isn't that much patient interaction. Yes, there is some patient interaction in peds and fluoro, but that's not enough. For some people, they want to do that. Like I said, from what I hear, it's patient interaction is one of the most overvalued things when you're trying to decide your specialty. What else? It's actually, some people consider it pretty boring. You come at 7 a.m. or 8 a.m., sit on a chair, and then you're sitting on the same chair. The only breaks you take is when you go to the restroom, or when you're drinking tea or coffee, and then you get up from the same chair at 5 o'clock. I used to enjoy it. I used to have pretty loud Punjabi music and full on, like it's a nightclub. It was pretty loud, and I was just reporting at the same time. I used to have a blast when I was, especially on nights, with loud music going on, and I'm just dictating, nobody else around. So that was me. But there are different people have different preferences.
So after training in the United States, how much scope is of radiology in the rest of the world? And what pathways can one take in different countries if they want to practice somewhere else?
See, I told you about all the pathways before. So, and I also told you that you can go to any part of the world and practice. It depends on the country that you're going into. They might have some local requirements that you might have to get some extra certification or pass their exams. Based on what I know, most of the places pretty much accept anybody who's a US diplomat who has passed the board exams. They can go and practice without any additional exam. They might need some extra certification. Like if I need to come and practice in Pakistan, I need just some certification from PMDC, but then I can come and practice. And same thing, if I if I want to practice in Saudi Arab or Dubai, I just need a certification or license from their local governing bodies, but I don't need to take an additional exam or something like that.
All right, so next question is, can you do remote practice from home in radiology, and at what stage of career?
You can do it fresh out of residency. A lot of people I know, they don't opt for fellowship, and or some people do the fellowship in emergency radiology. It's not needed, but it makes you more marketable. But a lot of these people do locums work, general radiology work, or emergency radiology. Most of the emergency radiology jobs, more than half of them are from home. So they provide you a station and you can read from home.
And next question is, what are considered to be the top institutions / hospitals with best radiology programs? You can aim for them in the United States.
The ones you can't get into. So in short, there are some really good ones: UCSF, UC San Francisco, Stanford University, Johns Hopkins, Harvard, WashU, UPenn. These are all the top ones, but it's very, very tough to get into these programs. They will only take one IMG in 20-25 years. So these are the places where a lot of American graduates go into. As an IMG, because radiology is so uber competitive, I think whatever program you can get into, that's a good program for you, because more than likely, even after doing all that, you're not going to get into Johns Hopkins or Stanford University. Yes, there are some successful people who have done residencies at Harvard and Northwestern and Yale. But it's radiology is very, very competitive, and there is top tier, mid tier, and low tier. So if you settle for mid tier, low tier, that's there's a higher chance of success. If you're just like, I'm just going to be going to one of the top tier, it's possible. And like I said, there are people who have matched in there, but I will say 20% of the people are able to match in the top tier. The rest, 80% of the people who match, they actually match in mid tier or bottom tier programs.
Can you do much research as an undergraduate in radiology, and will it build for CV in the radiology?
Absolutely. And that's one thing I tell all the younger medical students, first year, second year students, start early, And that is one thing that really helped me because I started early. I was able to do observership. It wasn't in radiology, it wasn't internal medicine in third year. And by the time I reached fourth year, I talked to a lot of people, a lot of IMGs who successfully matched into radiology. So I was able to talk to them. And the guidance I got was that try to publish at least an abstract or a case report when you're a medical student. So when I was rotating as a medical student, I asked them, all the attendings that I work with, if you guys have a case report that I can work on, do you have an abstract I can help you with? Do you have any project that I can help you with? It took a long time, but I was able to publish a case report. That was my first publication. But that really helped. Having contacts, the power of networking. It's not that you know people and that is the only factor that's going to get you the residency spot. It never happens like that. The power of networking is the access to accurate guidance. So the people I talk to, a lot of them are senior attendings now. Somebody is a chairman, and now they're all my friends, right? So in your station, reach out to as many people as you can in your specialty. So if you want to be a radiologist, talk to all the people who have matched from your country or any IMG who has matched into radiology. Who's a resident, who's doing research today, listen to them and, do projects, little projects, case reports, abstracts, stuff like that.
Okay, so here's a question that I got from a YouTube comment. They asked that if there is any benefit in doing double residencies.
Yes and no. Yes, let me say no. No, because you're wasting 3 to 5 years of your life in something that you're not going to practice. So that's a very superficial answer. But yes, because see, whatever you learn in life, a skill or knowledge, it stays with you. Nothing is useless, right? So people who did internal medicine residencies, they were excellent clinicians. We didn't even know how to open Epic or electronic medical record, and they knew all that stuff, right? They knew how to look at the EMR. They knew much more about patient. They are much better judge of looking at the notes and figuring out what's truly happening with the patient. So that skill stays with you, right? Some of the people who worked with me who were clinicians or did an internal medicine residency before, they were able to perform better. They were able to make better diagnosis looking at the images because they were able to do clinical correlation themselves. A couple of people I knew, they were physically to see the patient, they examine the patient, they will come back and then they will look at the scan and they will be able to interpret images much better because they have the clinical aptitude and that a lot of radiologists lack. So whatever you do in life, the skill and knowledge stays with you. But if you have to make a decision, I will still say the pathway one of doing research and then going into radiology is much better. That being said, if you're doing a medicine residency or if you have done a medicine or neurology or PEDS, any residency and you're trying to switch, don't think that your residency training has completely gone to waste. It is going to help you, become a better radiologist.
So next question is by far the most common question. Is people are concerned about AI, that is artificial intelligence, replacing radiologists in the future. What are your thoughts on this?
Yeah, I find it amusing actually. In final year of radiology residency, most of the resident programs participate in this program in which the top AI people from the country, they sit with you like remotely in a Zoom-like fashion or Skype conference. They sit with you and you study stuff and you discuss the same subject. Actually, if AI is going to replace them, that's never going to happen. And we have had this discussion before, and I've answered that the reason it won't happen is because in US specifically, you need somebody to sue. You need somebody's license on the line. So who's going to assume the medical legal liability? And I give the example of Tesla. Tesla has an excellent AI for driving, but is Tesla ever going to assume the liability of an accident? No. Eventually, it's the car seat driver. So just like that, I think what AI will do is, if the expectation is that you need to read 50 CAT scans a day, it might become 100 CAT scans a day. AI will help you read faster, read more efficiently, and read better. I don't think it's going to completely wipe off or replace diagnostic radiology. We have AI in breast imaging that's used pretty well, and it can never replace a well-trained breast imager. It helps them. It can help them read the studies faster and provide better reads, but I don't think it's going to entirely replace it. There needs to be a lot of research in saying that an AI can completely replace a diagnostic radiologist. And at the same time, if a company is able to come up with an AI model like that, the problem is who assumes the medical legal liability? Who's going to get, whose license is going to go to the court? Is it going to be of the AI model or the radiologists? For those reasons, I don't think AI can ever replace a diagnostic radiologist.
So next question is, what extra effort does an undergraduate need to do if they want to pursue radiology in US, specifically undergraduates?
Try to learn better, like anatomy, very good. You should be very good with anatomy. First thing. Second thing, start preparing. And a lot of these things are general, right? Start preparing for USMLE sooner. Try to talk to as many people who have matched into your specialty of choice, in this case, radiology in US. Try to talk to as many people as you can. The more people you talk to, the better aware you will be of the expectations. Start preparing for USMLEs early. Try to score as high as you can. Try to take them as soon as you can. Try to get electives in radiology. I did, I think, 4 months of electives in radiology. That really helped me. I was able to get some contacts in radiology. Then after, I was able to leverage my contacts from electives into getting a research in radiology. So you can do that. It's doing the basics right. Good scores, good CV, personal statement, doing long-term research, publish papers, have presentations, have abstracts, have case reports, at least something to supplement your CV. Good scores alone are not going to help you get into any competitive specialty, including radiology.
So next question is, what are the main checkpoints IMGs have to focus on while applying for radiology match?
See, the same thing. I think it is very, very important to have radiologists work with you before, like you have done some research in radiology. That's very, very important. So if you have done some research in radiology, your mentors are automatically write you some letters. So that's very important. Good scores, of course, but scores are always going to help you big time. But even if you don't have good scores, then your research becomes even more important. You can make up for scores with great research. So the same things, good scores, research, publications, abstracts, good letters of recommendations. If your mentors can make a phone call for you to the programs that you're really interested in, that helps you a lot. Yeah, that's mainly it. Good interview skills. And, these are all the things that I've already talked about in all my videos. So I would suggest, please listen to those videos, how to write a personal statement, how to have better interview skills, how to build a good CV, do research, try to get a good letter of recommendations, try to have, if your mentors can make phone calls for you, recommending you, something like that.
So next question is, do we have to apply to diagnostic radiology and interventional radiology separately, or we can go to interventional radiology after diagnostic radiology residency?
I think as of right now, you apply separately because now it's interventional radiology is a completely separate residency. And the transition happened like 2 years ago. To learn more about it, I interviewed Dr. Rahman. He's an interventional radiology fellowship director. So I would suggest you to watch that video, and he talks about it in detail. But I think for next 2 years or something like that, there is still a pathway that's open that if you do a diagnostic radiology residency, you can still do an interventional radiology fellowship that will be 2 years. But I think they're eventually fading away from that, and it's eventually going to die off. And then interventional radiology is going to be completely separate residency.
So the next question is, does year of graduation more than 5 years affect radiology match?
Yes and no. It depends what you did in those 5 years. So if you didn't do anything in those 5 years, then it really matters that, what were you doing in those 5 years? It looks really bad that you were doing nothing and just being at home. But if you were doing some significant research, like I said, if you were doing a PhD in research, if you publish multiple research papers, it looks very nice. One thing I will say is try to apply for match in your second year of research. So, if you can't do that, do it in your third year. But, and I'm glad you asked me this question. I actually So when I was telling you that I was going to US doing electives as a medical student, right? So I was doing electives, and wherever I will go for electives, I will try, irrespective of which specialty it is or wherever it is, I will email the program director of radiology, and I'll request them if I can sit with them for a brief chat and ask them how to get into radiology as an IMG. So I met the program director at Yale, um, and I asked him the same question that you asked me, and he gave me this answer 12 years ago, which I think was an excellent answer. And he said that when you do research, your chances of getting into radiology increase, and that graph goes up like this. Okay, and the longer you wait from your time since graduation, there's another graph that's plotted with time since graduation versus success, likelihood of you matching. That is coming like this. Okay, so the longer you wait, the less are your chances of matching into any residency. So he said the sweet spot is 2 to 3 years where both these graphs intersect. So 2 to 3 years, if you are able to match during this time, the year second of research or of research, that has the best chance of success, as compared to if you do 5, 7, 10 years of research, you can still match, but the likelihood is much less. And same thing, if you start too early, like if you're applying within 6 months of the first year, you can still match, but the chances are relatively low.
So the next question is, when applying for the radiology match, do all your LORs have to come from radiologists?
No, no, it doesn't have to. So you need 4 LORs. It's better if you have at least 2 LORs from a radiologist. You can certainly use 2 LORs from non-radiology people.
So the next question is, I've been wondering, how hard is radiology work on your eyes?
Oh no, it's a myth. You'll do just fine. It's okay. It's not that hard. You get breaks, and you get used to do it. It's like watching a movie. How tired do you get after watching 2 movies? I don't know if you like it. If it's your passion, you do just fine. I never had any issue.
And here's a similar question, that I was wondering if radiation exposure is significant concern in this field.
It depends what you're doing, right? If somebody's doing a lot of fluoro procedures, if somebody's an interventional radiologist, yes, but they have a very you will learn a lot about protection in physics. So you will learn how to protect yourself. Second, you will have to wear heavy lead, and they provide you with all the protections. If anything, I will like sometimes I'm like, why do I have to wear all this protective stuff? Like, you will wear protective eyeglasses, you'll be wearing lead. uh, it's not a big concern.
So the next question is, does a fellowship level trained radiologist's salary substantially differ from a resident level counterpart?
Okay. Interesting question, and the answer is no. You don't get a significant salary raise or pay raise after getting fellowship. You just become more marketable. Your likelihood of getting a good job increases after doing fellowship. That being said, your salary does not increase significantly. Yes, if you have done interventional radiology, they tend to get paid a little more than the diagnostic radiologists, but that's just because their work nature is different. You're on call a lot more as compared to diagnostic radiologists. But in general, most of the fellowship trained radiologists and the non-fellowship trained radiologists, they start pretty much at the same salary level. The only difference is you will read a different set of cases. They will read the tougher, so your life would be relatively less boring because you will be reading some high-end complex cases. For a general radiologist, it's more like bread and butter radiology. If you're okay with that, and there are certain personality types who like the diversity and they don't want to look at the high-end MRI or the complex cases, they want to do the bread and butter radiology. People like that do just fine. I don't think it's financially it's a good investment. That being said, you're investing in your skill set. It doesn't hold a monetary value, but you're becoming a better radiologist. You're learning stuff that nobody else does. And if you go to practice where nobody else is fellowship trained in your specialty, then people will come to you to ask questions.
So next question is, can you please explain in detail what your hours are like in your radiology residency?
It's very variable. It depends on the program to program. Typically, you start somewhere between 7 to 8, 7 a.m., 7:30 or 8 a.m. A lot of programs have a morning conference, so you have a morning conference till 8:30. At other programs that they don't have morning conference, you go to the pack station, you start reading at the view box, you log certain number of studies, let's say X-ray, CT scans, MRIs, ultrasound, whatever, and then you go to your attending around 9:30 or 10 o'clock, and you review all the studies that you have logged, and they tell you the findings and stuff, or the attendings comes to you and reviews the findings, and then you put in your dictations from 10:30 till like 11:30. Then around noontime, it's the lunch break. A lot of places have noon conferences at the lunch, when it's a time for lunch. So you grab your food and you sit in the conferences. They will show you images. They will teach you stuff. So either it could be, like a case-based teaching where they will show cases, or it will be just a plain lecture. Then around 1 o'clock, you go log new studies again, read them till 2:30, come up with your own findings and the impression. Then you go to your attending, review the cases, make sure your dictations are in by 4:30. And then most of the people get to leave around 5:30, 6. Most of the people I know, they leave, like I said, between 5 to 6. If you're on call, evening call, then you stay between 5 to 9 or 5 to 10, since you're on call. So you're reading studies after that. You generally do not take a call in your first year. First year, you take the buddy call. You're sitting with your senior resident, and they're showing you the findings and stuff. And then after that, you start taking solo call. And some programs, they have night hawks, the emergency radiologists. So in those programs, you don't work night shift. That being said, that I used to love working at nights because you're by yourself. You have an emergency radiologist who's available on a phone. So those shifts in our program used to be between 2 to 3 weeks a year, and it wasn't that bad. So in those shifts, you will start at 9 p.m. and you finish at 7 a.m. before the morning people come in, and you're reading everything by yourself, putting in reports. And if you have any questions, you can call an attending and ask them questions.
Okay, so the next question is how to get a US fellowship without residency for foreign international medical graduates.
Okay, like I answered before, a lot of people do research fellowships. So first you try to get a research fellowship from a top place, and then that would increase your chances significantly. Of course, if you have a good CV overall with case reports, abstracts, presentations, that will significantly improve your chances of getting into radiology fellowship. Also, I would say that, a lot of people, if you're applying for radiology fellowship, don't just apply for interventional radiology or breast imaging or neuroradiology, because these are the three most competitive fellowships. Apply for relatively less competitive fellowships. Start with nuclear medicine or pediatric radiology. So you're more than the chance of you matching into a relatively less competitive fellowship is more as compared to applying for the most highly competitive specialty. And then once you have performed exceptionally well in the relatively less competitive specialties, then you can apply for more highly competitive specialties. And people in most of the times you will be able to match into the highly competitive specialties in your own hospital. If you, let's say, you do a very good job in pediatric imaging and then in nuclear imaging, then you should be able to match into neuroradiology or breast imaging or interventional radiology. Interventional radiology, things change, but you should be able to match in neuroradiology and breast imaging because you did exceptionally well.
So that's it. These are all the questions that I received from you guys, and I hope that helped you. I know it did help me. So thank you so much, Dr. Tariq, for your guidance.
Yeah, thanks a lot for having me. In short, I will say radiology is an exceptionally well rewarding specialty. It is humbling, but it is extremely rewarding. I remember fourth year medical student, I came into radiology for the wrong reasons. I went to Heart and Body Scan Center, which is right next to Doctor's Hospital, and they showed me virtual colonoscopy. That was the first time I saw something like that, and I was blown away that, oh my God, virtual colonoscopy. People are getting their colonoscopy done without colonoscopy. So, I saw MRI and I was blown away by all the advances. That was one of the biggest reasons that inspired me to come into radiology. But once I came into radiology, I realized how little we know about radiology. Radiology has a lot to offer, and there's a lot of cool stuff happening in terms of AI, graphics, the progress, MRI sequences. we are able to visualize, diagnose, and even treat a lot more pathologies. We haven't even talked about interventional radiology. So it's very rewarding. Somebody's bleeding to death and they come to your table and you're able to stop their bleeding and they live for life for, after like 30 minutes. Somebody has cancer and you put a tiny needle and, you burn or freeze their tumor, and then their tumor is gone forever. Or somebody who's going to die in 6 months, you do an angiography, you inject chemotherapy, or you inject radiation, beads coated with radiation, and their tumor growth is decreased significantly. Even on the diagnostic side, somebody's bleeding to death or somebody's super sick and they don't know why they're sick. Is it appendicitis? Is it cholecystitis? Is it just a gastric ulcer? Or they're bleeding to death? It's radiology that helps them come up with the diagnosis. So, there's a lot of value that we provide in the healthcare, and I think it is an excellent specialty. It's just unfortunately it is not that valued, especially in South Asia and Pakistan and countries, because it's still developing as compared to in US is way more developed, and I think it's overall they're way more respected as well. And thanks for having me, Fatima. I'm hope I didn't scare you from committing to radiology. Okay,
Oh, it
good,
was very
good.
insightful. Thank you so much.
You're most welcome. And like I always say, you know, and this applies for anything in general in life. If you aim for a tough journey, a tough future, never give up, never lose hope. Good luck to all those who want to pursue radiology.